present is based on the work that I do and the research that I've done. But I have to say that what has me, what really drove me to do this work is more my personal experience. I am mixed race, and my parents separated when I was very, very young. And so I spent half of my life in a community that was 98% white, and the other half of my life, like of the year, in a community that was 98% black. And so very, very different experiences, but very, very similar experiences at the same time. And you'll see as I go through my presentation, I'm not only going to use what I've learned through my work and research, but I'm also going to talk a little bit about the experiences that I've had as a mixed race black woman living in the United States. And as someone who's also lived abroad and been the majority for 2 years of my life in a country where race was not an issue. At least my race was never an issue. So it sort of gave me some insight into how race plays out here in the United States. So today I'm going to talk about social and structural determinants of health. And I'm going to do this from an HIV perspective because I do HIV work. That's what I know about. And the thing that drew me to HIV was that HIV, in my mind, peels away the Band-Aid for what the underlying root causes of health, quality of life, and just general social and structural factors in our society. So I'm going to talk a lot about that. Basically, I want you guys to understand what social and structural factors drive health, not only physiological health, but psychological and emotional health. And, I want to also just discuss some strategies and tools that we might be able to use to combat some of these things. So what drove me to this interest was, my early work in HIV. And I was really, really interested in HIV because I saw HIV devastate my community. A very good friend of mine died at the age of 25. And he should not have died, and if a number of things had fallen in place, including acceptance of his gay identity and so forth, he would not have. And so that and other things have been a driving force in my desire to see something happen with regard to HIV. But what is fascinating about HIV is that if you follow the media, and if any of you hear things about HIV, you would think that the drivers of HIV are individual behavior, who people are sleeping with, how many people they're sleeping with, the drugs that they use. And in reality, those are risk factors, but those are not the drivers of HIV. Because if you look at the community that's most impacted by HIV, young black men who have sex with men are the biggest community impacted by HIV. And if you compare them to their white counterparts, they're not having any more sex, they're not having any more risky sex, they're not having any more partners, and they're not using any more drugs than their white counterparts. So none of those factors make any sense. And if you look at black women and you compare them to white women, black women could be doing the exact same behaviors as their white female counterparts, and they are still 5 times more likely to be infected with HIV. So it's not behavior. It's not what we are doing. So what is it? What is it that creates these huge disparities, not just in HIV, but in diabetes, in cancer, in cardiovascular disease, you name it. And it's not, most of the time, behavior. So what is it? For HIV, and this is something that people don't talk about, it's a combination of factors that play out in the black community. So in the black community, as with every community of color, it doesn't matter what your race is, what your ethnicity is, you are more likely as a human being to practice assortative mixing. So what is that? That's a fancy scientific word for saying that if you're black, you're more likely to have sex with and date another black person. If you are white, you're more likely to have sex with and date another white person. Now, obviously, that's not always the case. I would not be here if that were always the case. But black people, more than any other racial group, practice assortative mixing. So what does that mean in a place like Seattle? How much of the population do we make up in Seattle? Does anyone know what the percentage of black people are in Seattle?
2, 7.
It's low. It's low.
It's 9.
It's 6. It's between 2 and 7.
Okay.
Good job. It's 6. So if you think about 6% of the population, if you're heterosexual, that means that you have a 3% of the population that you could choose from if you're only dating black people. So 3 out of 100 people you could consider dating. If you are a black gay person, you make up about 1.5% of that 6%. So you can date about half a person for every 100 people that are out there. So what does that do to your dating network, your sexual network? You have these tight sexual networks. And human beings, especially when they're dating, tend to go from relationship to relationship and sexual partner to sexual partner, especially when you're young. So if you think about sexual networks in terms of how tight-knit they are, and you think of the difference between a white sorority girl at University of Washington who during her freshman and sophomore year will probably have an average of 5 to 6 partners, and you compare her to that black man who has sex with men who has 5 or 6 partners in a tight sexual network where HIV has already entered the network, his risk is 70 times more than her risk, and she's doing the same exact behaviors as he is. So you have this combination of assortative mixing, tight sexual networks, and then when a disease that's sexually transmitted gets into these networks, and you have these overlapping partnerships, which happen in every community. It's not a black thing, it's not a white thing, it's a human thing. But this combination of events creates faster transmission of HIV, more people getting infected, higher viral load in your community, and the higher the viral load in your community, the more chance you have of coming in contact with the disease. And that, in a nutshell, is what we see in black communities all around the country. But yet, that is not the public health message that we hear. We hear reduce your partners, stop using drugs, stop having so much sex, none of which have worked, by the way. And then, what we also see, which I'm going to spend the majority of this talk on, are these disproportionate social and structural factors that impact everyone in this country, but have a particular impact on communities of color. And whatever impacts communities of color, generally speaking, black people get the short end of the stick in almost every situation, with the exception of a few where our Latino and Latina brothers and sisters get a much shorter end of the stick, or our American Indian and Alaska Native folks are getting a much shorter end of the stick. Or if you take Cambodians and Vietnamese out of the Asian population, they're getting the shorter end of the stick. And then there's also stigma. And so HIV is still very much stigmatized. There are still people who I see who have to come in the back door of the Madison Clinic, who my colleagues see at the Madison Clinic, African-born people particularly, who don't want to disclose because they're afraid of what it means. So if you are stigmatized, you're less likely to disclose, you're less likely to tell your partner that you're HIV positive, and it creates issues in the family or in the community, because if you don't think anyone in your community is HIV positive and you're not at risk, why would you go get tested? You know, it's those people, not me. And that's the real challenge that we have with stigma still. But I'm not going to really talk about stigma because I don't have time. I'm going to focus my presentation on social and structural factors. And the reason I want to focus my presentation on social and structural factors is because these play out in the same way for every disease category, not just HIV. So I could be standing up here as an oncologist, as a cardiologist, and I would be saying pretty much the same thing that I'm saying now about HIV for a lot of those diseases when it comes to these social and structural factors. And the ones that I want to focus on the most are poverty, because a lot of people say it's not race, it's class, and so I want to discuss that. And I want to talk about what I call the assault on black and brown men. And that is the trifecta of infant mortality, male homicide, and incarceration. Those three things have created a warlike environment for black and brown men in this society. And I know that that's a very inciting thing to say, but I will back that up with some data. And then on top of that, I want to finish the talk with stressors. And I'm going to talk about stressors from a historical perspective and what we know about the impact of historical trauma on health and well-being. And then I'm going to talk about not only the historical practice, or only the historical impact of trauma, but the day-to-day stressors of discrimination and microaggressions that sit on top and exacerbate that historical trauma. So I borrowed this slide from someone who I respect greatly, Dr. Thomas Leviste, who is at Johns Hopkins. When he started at Johns Hopkins, he was the only African-American professor, and he has now built a cadre of African-American faculty around him, and he's just fabulous. And his work looks at the question that everyone asks: is it really race, or is it about income? So he talks about these four great race disparities. And he calls them race disparities because they fall out among racial lines, and that'll be clear soon. But he talks about health, education, criminal justice, and wealth. So how do these four factors work together to create the social and structural barriers that we see that impact health and well-being? Well, let's talk about criminal justice and education. In the criminal justice system, there are high levels of illiteracy. So people are not getting educated. There's no educational attainment among these incarcerated individuals. And what is the best way to keep people from being educated? Institutionalize them at a critical period of educational attainment. If people are institutionalized when they should be educated, they will never, in many cases, be able to recoup that educational loss. And then, what's the connection between criminal justice and wealth? Well, it is a well-established fact. You could read the law journals. You don't have to read the law journals. Just go downtown. If you do not have money, you are not going to get equal representation in the criminal justice system. You have to pay to get a better lawyer, And a better lawyer has an impact on whether or not you're charged, whether or not you're sentenced, and how long that sentence will be. So, wealth and criminal justice intricately tied. The other thing about criminal justice is, how do you effectively bar the accumulation of wealth? Most people in the United States, unless their wealth is passed to them intergenerationally, accumulate their wealth between the ages of 17 and 34. So what is the best way to effectively block the accumulation of wealth? Institutionalize people during the critical period of wealth attainment.
Wouldn't that also suggest, Michelle, that that's also the best kind of profit margin when you want to limit people? You got their very best work years.
Yes, yes, exactly. Because this is when they are most productive, bringing in the most resources, generating capital, and so forth. And so not only does this have an impact on the individual and the family, this has a huge impact on our society as a whole, because we're crippling ourselves by not allowing our gross national product, which is the individuals that comprise our society, to be the most viable when they can. We're effectively cutting that off and institutionalizing them during their most productive years. So yes, excellent point. And then what's the connection between health and wealth? Well, the more resources you have, the better access to care you have. But I would argue that we focus way too much on access to care. I think that it's more about quality of care. And I say this from my own personal experience, because when I was in grad school, I worked at the community hospital at the University of Miami, or it wasn't the University of Miami Hospital, but it was the Dade County Community Hospital. So, and I was working in an HIV clinic for women who came in to get their PAPs, to get their OBGYN care. And we would schedule 25 women for 9 a.m., 25 women for noon, 25 women for 2, in a clinic that had 2 nurses and no TV, no toys for the kids, and these women would come and they would get good care. We had excellent nurses who were very dedicated, really good care. But these women would sit there from 9 in the morning to sometimes like 1 or 2 in the afternoon before they got seen.
With their kids?
With their kids. And because they have no child care.
Exactly.
These women are, you know, if the U.S. is a caste system,
Right, definitely.
which some people would argue it is,
It is.
they were at the lower rung of the
Right.
caste system, and they had no child care, and if they were working, they weren't working at jobs where they could take a whole day off. That means they lost pay.
Exactly.
So it's the quality of care, not just access, but
Right.
quality of care that these women and men are receiving. And then insurance coverage. Prior to the Affordable Care Act, insurance was something based on resources. And although the Affordable Care Act, many would argue, is not perfect, it has certainly increased insurance coverage, which we'll see later. But insurance is a huge deal. For any of you who've ever been sick, and if you haven't had insurance, then you know how much that can burn, because you are then saddled with a huge bill. And then we talked about we talked about literacy, but health literacy is incredibly important. So if something goes wrong with you, do you know how to take care of it? Do you know what to do? If you are trying to prevent an illness, do you know what steps you need to take? What prophylactic measures you need to prevent an illness? All of that is really important. But I would argue that the biggest connection between health and education and wealth is knowing how to navigate the system and having people in the system that you can go to. You know, as someone who grew up in the projects, my mom had no one that she could ask, no doctor friends. We didn't have friends who were nurses. And now, as someone who works at a hospital, if something goes wrong, I can just call someone. That is such a privilege that most people don't recognize as a privilege. Many people in this country have no resources to navigate a system which is incredibly complex. Our healthcare system is incredibly complex. So I would say that navigating the system is a huge, huge burden for many people. And I just wanted to show you sort of how this plays out a little bit. In HIV, we're worried about the cascade of care. So we're interested in, of the people who are HIV positive, how many of them are diagnosed and know that they're HIV positive? Of those who are diagnosed, how many of them are linked to care? They have a doctor that they're seeing and they're getting their care. And of those who are linked to care, how many are retained in care? They see their doctor regularly. And of those who are retained in care, how many are prescribed